I have quite an easy task this morning, and thank you for inviting me, and thank you to Stellas as well. The role of the first generation hormone therapy, I'm going to cover a number of issues which have been well demonstrated in the literature, but indeed it is always useful to re-establish what is well known and what we should do in clinical practice. So what are we supposed to do with the use of hormonal therapy when we are recommending a patient to undergo radiation therapy? This is essentially related to patients who have an intermediate risk prostate cancer. This is one of the landmark trials that have looked at the combination of an LHRH agonist together with an anti-androgen given during the first month of treatment, and as compared to radiation therapy only. If we look at the classic oncological parameters that we can observe in our patients, like biochemical recurrence-free survival, distant metastasis, and specific mortality, there is a clear difference if we do use the hormonal treatment together with radiation therapy. This is a message that has gone through the radiation oncologist arena, and it should be very well clear also to us urologists when we are talking to our patients. Indeed, we know that there is a difference when looking at those who have favorable versus unfavorable risk factors, but the advantage of hormonal therapy still remains. So patients with prostate cancer, intermediate risk, radiation therapy, use hormones for a short period of time. What are we supposed to be doing when talking to our patients with high-risk prostate cancer? We all know that androgen deprivation therapy has a significantly positive impact in this scenario. A question would be, how long should we keep it on in these patients? Historically, it has been proposed that it should be for at least 3 years, and this has been followed by many radiation therapists and urologists all over. And the question in this study was whether we could take it down to 18 months. And indeed, in terms of overall survival, those being treated for a shorter time with hormones were doing at the same level, were doing fine. When looking at disease-related death and biochemical relapse, the results were not significantly different, as one would expect in terms of quality of life if you apply one of the various scales that we may use to assess the impact of a medical treatment like this one. Patients would be happier if the androgen deprivation therapy use would be shorter. So the take-home message here would be to recommend your patients to have it for 18 months and no longer. When we do radical prostatectomy and we observe a biochemical recurrence, this is unfortunately quite common in our everyday practice. What are we supposed to say? If you look at the second half of the slide, when looking at the very last version of the EAU guidelines, when a biochemical recurrence after surgery is there, monitoring should be considered for a certain number of patients. Clearly, there are predictive factors that we know well that we should consider, and the issue of salvage radiation therapy is indeed coming out with more and more strength. In this scenario, I presume you are all aware of this study published in the New England Journal of Medicine, so coming from the US, where bicalutamide was used for 3 years in patients who would show some form of biochemical recurrence. Indeed, if you look at the level of PSA, it's very wide. It would go from 0.2 to 4. Probably, I would suspect that none in this audience would think of waiting until a PSA of 4 before starting treatment in our patients whom we had initially treated with a radical prostatectomy. So this has to be considered. There was a difference in terms of survival between these two groups. There was a lot of discussion out of this paper, a lot of comments, of interesting comments also in the editorial comment that accompanied the paper. And if you look at the forest plot here, it's quite evident that those who were very bad patients to start with, take those with a PSA greater than 1.5, were those who would benefit from this treatment. So a study started a long time ago, and so we should balance these results with what we see in everyday practice today. But indeed, if you consider using anti-androgen therapy in this patient category, you are not doing anything wrong. This is a study coming from France, from a GITUG, where patients after recurrence, biochemical recurrence following radical prostatectomy have been randomized to receive radiation therapy or radiation therapy compared with 6 months of an LHRH agonist. And again, here, the results are suggesting that if the LHRH agonist is used, there are indeed better results oncologically speaking. And so 6 months would suggest to give you already a result. There are many studies coming out in the field of metastatic disease, specifically hormone-sensitive prostate cancer. We know that LHRH are considered and authorized to be used with the recurrence after local treatment. But now we have these new areas of interest brought to all of us by the STAMPEDE and CHARTER trial, where the combination of chemotherapy plus an LHRH agonist has been suggested to be effective in patients who had very bad disease to start with. So there is a lot of discussion about who should really receive this, but indeed in the 2 papers that amplify this result, there was an improvement of up to 1 year. So it's something that we cannot avoid to consider. The latitude is the new idea of increasing the blockade of the testosterone cascade by combining an LHRH agonist together with abiraterone. Indeed, the results were there. Going back to the charter, this is graphics that you all know well today, and the difference is there. Same, although the trial was slightly different in terms of design with STAMPEDE. So the point there, once again, a patient who comes out with metastatic disease de novo with very bad conditions should be considered also for this type of treatment. And this is, again, the forest plot suggesting that the area of the combination therapy is always on the right side. Still discussion about why there were differences between one study group and the other study group, probably also a patient selection issue, but I think that this is a message which is going through. The latitude is what I was mentioning to you. Indeed, data are there. At least in a country like mine, the issue would be from the regulatory side today, because this would not be approved yet, which means that if a patient wants to receive this type of combination treatment and he does have the profile to receive it, he would have to pay the treatment from out of his pockets, which is clearly quite expensive. But you see here who would be the patients who would benefit by the combination of the two. This is something that is important. I think it is a rule that has been captured better from urologists as compared to many medical oncologists or radiation therapy oncologists. What I mean is that the LHRH should stay in the protocol also down the line, and you should not interrupt that. And this is leading us to the castration-resistant arena, where there are a number of studies in which the new products have been studied together with the maintenance of an LHRH agonist. That is something that should always be considered. Although we have been talking about LHRH agonists, I think that there are certain factors that should be considered. We all recognize the importance of really being able to create a chemical castration state, which means to have a testosterone serum level of less than 20 nanograms per deciliter. This is obtained specifically by some drugs and not others, and it is something that we should consider. And at the same time, we should look at the efficacy of treatment and also the safety of treatment, and looking at the issue of quality of life, metabolic, and especially cardiovascular. The very recent version of the EAU 2017 guidelines have been recommending that there is a suggestion that LHRH agonists could be associated with lower cardiovascular morbidity than the agonist. Indeed, I think we all agree that we don't have today a study which is robust enough from the methodological perspective to really state this. And I think it is important when deciding what to do with your patients. This study coming from France, a post-marketing trial, is actually showing that the difference, I will skip this, which is busy, but this is the important slide. The difference between LHRH agonists and antagonists is not really significant, which means that I think that you should consider every single patient that you have in front of you and feel free to proceed with the therapy that you consider the best. As I said at the beginning, very robust information today, so an easy task. Patients with intermediate risk prostate cancer, the combination of radiation therapy and androgen deprivation therapy must be considered. Those having high risk prostate cancer, not only the combination therapy should be considered, but it looks like that if you use androgen deprivation therapy for 18 months, then it is enough. ADT remains the backbone of therapy. Also, when down the line you need to use other drugs, and this is something that has to be considered. And the LHRH agonist should be maintained, and the profile risk in terms of side effects of both antagonist and agonist is pretty good. So with this being said, I think it is a good scenery to continue. Thank you very much.
Thank you, Francesco. Please take a seat. We have some time for discussion if you want to, you have a point maybe. Guillaume, you want to raise the question? You have something in particular in mind? Me, I was wondering, we have a lot of data in the literature about androgen deprivation and radiotherapy. There is always the question when we make more and more cases of high-risk surgery, and we have been seeing a radical prostatectomy. Of course, the evidence is in favor of delivering a deprivation after a prostatectomy when you have one single positive node. But what is your attitude? What do you think? Because there is the evidence, but some people are criticizing, saying that there are in fact few studies demonstrating that the methodology is good, but the population was not large enough. So what do you do when you have been doing a high-risk radical prostatectomy and you have just a single small node invaded? Do you decide systematically to go for the deprivation?
Excellent question. The answer is a straightforward no. Indeed, the difference between what we see after radical prostatectomy in the high-risk patient category and that we have more information as compared to those who receive radiation therapy. We know especially everything about the final pathology, about what is really at the end the pathology of clinically high-risk prostate cancer, and we know something about we know everything about the nodes. So generally speaking, those showing at least two bad predictors like a Gleason score 8 or more, or a positive seminal vesicles, or a positive lymph node, they should be considered for adjuvant radiation therapy, which would be, Morgan, the first thing that we would consider, perhaps together with androgen deprivation therapy. But I think that at San Raffaele, we have stopped giving androgen deprivation therapy as the single adjuvant therapy in any of our patients. And this started many years ago. To go back to your question, one tiny node, final pathology not bad, the guy would be observed.
Okay, good to have your point. May I ask if you don't mind Nicolas, because I know he's there and he's very well aware of what's Nicolas Motet is just there. What's your opinion on this point, Nicolas?
One single node undetectable PSA. We clearly said in the guidelines that you have three options. Evidence-based adjuvant ADT, an option if the PSA is undetectable, one single node out of an extended nodal dissection. Wait-and-see policy is probably the best way to go. But the evidence to support that is minimal. There are very, very few patients reported together. There's no randomized trial. And probably if you have a very high risk based on a number of nodes, and again, it's not from a prospective trial, combination of radiotherapy plus ADT, provided not a huge number of nodes, radiotherapy is probably useless, and you have a significant Gleason. But again, the only level 1 evidence is for adjuvant ADT.
Okay, thank you. You have a point, Alexandre?
No, it's not a point, just a question. What do you discuss with your radio-oncologist for the radiation? You ask for radiation of the prostatic bed or the entire pelvis?
Excellent question. At our own place, the radiation therapists are very keen on considering the use of radiation therapy not only to the prostatic fossa, but also to the pelvis. And so that would be the attitude in most. Of course, we would consider the final pathology, but that would be the typical attitude from them. One comment that I would like to make is probably as compared to the past, we are no longer looking only at the final pathology to make our decision, but as the chairman is saying, also to the first postoperative PSA, which is something that has to be explained to the patient before doing the surgery, because they are so anxious, patients, families, and they expect us to tell them everything only on the basis of final pathology. And we know that more and more that is not enough.
Thank you. We need to move on with the program. So Guillaume, I will ask you to go to the microphone, and we are going into the heart of the discussion of this symposium. It's about first-line treatment in metastatic castration-resistant prostate cancer. So we're listening to you, and maybe we'll discuss a little bit further after. Thank you.